Jeanette Segeren graduated from the University of Toronto Occupational Therapy program in 2016 and completed her graduate certificate in driver rehabilitation from McGill University in 2020. She is currently working at the Chatham-Kent Health Alliance in the outpatient neurorehabilitation program, where she specializes in supporting individuals recovering from stroke. Living in a rural community, Jeanette is passionate about helping people return to driving safely and supporting her peers by providing guidance and evidence-based support across the continuum of care. In her spare time, Jeanette can be found chasing her 3-year-old around the house, trying new recipes, and spending time with friends and family. Welcome, Jeanette.
Thank you very much, Ashley, for the introduction. It's a pleasure to be here. I've really enjoyed the morning session so far. And I'm really looking forward to attending the afternoon as well. So thank you so much to Sue and to everybody who is attending. It's such an honor to be asked to speak, and I hope you take some good takeaways from my presentation, as I know I've taken a lot from today already so far. Today, I am going to talk a little bit about driving after stroke, specifically focusing on the development of a patient resource booklet through the Southwestern Ontario Stroke Network. It's a bit of a mouthful, so we often refer to it as SWASN. And just a big thank you to Libby Forbes and Martha Scott, who were instrumental in helping me kind of put together this presentation and figure out what exactly to focus on, because it is a really big topic. A quick disclaimer here, we do try to be as accurate as we can in terms of our information, but there's no guarantee to that effect. Research is evolving every day, every month. And so, for the most up-to-date practice recommendations, asking providers to refer to the Canadian Best Practices website. So today we're going to start by talking a little bit about driving after stroke, talking about how we address it across the continuum of care. We'll talk about the 2024 SWASN resources, and then I'll go through a case study which will kind of demonstrate how to use these resources in real life, in a practical scenario. I'll quickly highlight some other resources that are available in the community, and then we will have time for questions as well. So talking about driving after stroke, we know that driving is an important activity of daily living. It's essential for completing daily tasks outside the home, whether that's attending doctor's appointments, therapy appointments, going to the drugstore, going shopping, getting groceries. It also helps connect people socially. I always think of my OPA or some of my patients, and they have the morning meeting at Tim Hortons. And that's a really wonderful way of connecting with friends and coworkers. It's also important for vocational work, whether that's getting to or from work or working or driving as a part of what they do for their work. It's also seen as a symbol of independence and freedom. So this is a particular note in rural and remote communities that have those limited public transportation options. So this is a really big thing in the community where I'm practicing, Chatham-Kent, quite a rural community with not a whole lot of alternative driving supports. And I know this is a big barrier in Northeastern Ontario. My mom grew up in Kapuskasing. I have a lot of extended family up north, and having gone up there my whole life, there's not a whole lot of readily available public transportation like you might get in a bigger city like Toronto or London or Ottawa. We know that after stroke, there are many issues that can impact somebody's ability to return to driving. I've kind of highlighted some key areas here on the slide, whether it's the physical ability to manipulate the primary or secondary controls of a vehicle, cognitive issues, somebody's ability to um, sustain their attention to the driving task or divide their attention between within the car, somebody speaking in the back, and the what's going on the road, their memory, problem solving, perception, their ability to stay within the lanes or spatial awareness. How far is the car in front of me? Attending to the full visual field, that unilateral neglect. Then there's some speech and language components as well. Somebody's ability to interpret road signs in a quick and accurate manner, and read writing on road signs as well. Of course, there's a strong visual component. After a stroke, somebody might have diplopia, or they might have difficulty moving or activating a muscle in the eye, or even have a visual field cut, which may impact their ability to return to driving. And of course, there's that medical aspect as well. So is this person at risk of suddenly becoming unconscious at the wheel, whether that's due to a medical condition? We think of kind of epilepsy, or we think of somebody who has like a active substance use disorder that's not medically managed, some cardiac conditions, or even it can be medication related. So there's a lot of components that we need in order to be able to drive safely. And these things can be impacted after stroke. In terms of a recovery timeline, there is no one size fits all answer. And I always tell my patients, I don't have a crystal ball, but what we do know is that we see the highest rate of functional recovery within the first 3 months. But there is ongoing recovery up to and past 1 year, as you can see here in that chart. The literature is a bit divided in terms of what percentage of patients return to driving after a stroke. The general consensus is approximately 30 to 66%. A 2022 meta-analysis found that individuals that waited longer to complete an on-road assessment had higher success rates of being cleared to return to driving after a stroke. Taking a peek at the Canadian stroke best practices, this is taken directly from the website. I'm not going to get too much in depth with it. You do have the slides available. But in terms of education and screening, the person should be made aware if their license has been reported. And the best practice recommendation is that individuals be asked to stop driving for at least 1 month after stroke. In terms of assessment for fitness to drive, I know there's a presentation right after me that's going to delve a little bit more into this, but people interested in returning to driving following a stroke should be assessed for their abilities using valid and reliable methods. In terms of rehabilitation and management for return to driving, after stroke, people who are interested in returning to driving should be offered appropriate rehab in order to increase the likelihood of returning to driving. And finally, people who are unable to return to driving should be offered supportive and counseling, as well as have that conversation about transportation alternatives. So keeping these best practices in the back of our mind as this is kind of how we address driving in the most fulsome evidence-based way. So I'm going to quickly talk about how do we address driving across the continuum of care. And as an occupational therapist by background, I'm kind of going to talk about the OT scope of how I approach this, but I think it's important for, across all disciplines here. So in an acute care setting, somebody, whether it's in the ICU, if they got TNK or TPA, or the medicine unit or a stroke unit, our focus is really screening for deficits. They're being managed medically, but from a therapy perspective, from a driving perspective, what are we seeing? What are the deficits of of this stroke? And then does this person require rehab, or would they benefit from rehab? This is really where education for the patient and the family needs to start. Often people can be discharged straight home from acute care, and you know, even if they're not, it is going to be something that comes up because it's such an important occupation. So if somebody's discharged straight home from acute care, you know, we're looking at alternative driving plans, we're referring to specialists. And this is where that discretionary for occupational therapists and mandatory reporting for NPs, physicians, and eye specialists come into play as well. On a rehab unit, we have a little bit more time with the patient. So here's where we really focus on in-depth assessment and treatment of those stroke-specific deficits. There's really a remediation approach to therapy as opposed to compensatory. And really a big focus, and I think this was alluded to earlier on the rehab unit, is can we get this person home safely? So we do talk about driving. Again, this is where the education continues, but a focus of rehab is really those ADLs. Can they get home safely? Again, at time of discharge, looking at those 3 points here: alternative driving plans, referrals to specialists, and reporting of the license. Now, in the community where I practice primarily, that in-depth assessment and treatment continues. We're assembling information for the specialist or the most responsible physician, and then we're taking both remediation and compensatory approaches depending on how long it's been since their stroke and if we're seeing kind of a plateau in terms of functional recovery or if they're continuing to make gains. Now, in the community, in my practice, that's where I find a lot of people have like the bandwidth to really focus on driving as one of their primary goals. So this is, of course, where the education continues. We're still talking about alternative driving plans. Often somebody's discharged from the hospital. There is a lot of doctor's appointments that they need to get to. There's a lot of therapy appointments they need to get to. And so coming up with those alternative driving plans is really, really important. We're also referring. Generally, this happens in the community to, we're referring for the on-road assessments at this point in time, because enough time has passed that it would be beneficial for them. So as you can see here, education is always a focus throughout a patient's stroke journey. And because we're touching upon it often, it is helpful to have some written materials in order to help keep the messaging consistent, as well as helping the patient and families retain that information. So we talk about the target audience for a standardized handout. Of course, we have the written information that helps patients and families retain the information and understand the information, and remember accurately what we're telling them. The number of times that I've seen a patient and we talk about driving and outpatients and they say, "Oh, I waited the 30 days and then I just returned to driving," because all they remembered was that 30 days. It happens more often than I'd like to see. But having a standardized handout that they're kind of given across the continuum of care, you know, they can refer back to it. Oh, it's not just 30 days, and I need clearance, and my license must be reinstated. In terms of supporting providers, a standardized handout really helps, again, with that consistent messaging so that we're not confusing the patient from a provider to provider standpoint. So when I'm talking to a patient, they're not getting a totally different information guideline from another provider. This keeps everything very, very consistent. I'm lucky enough to work in a stroke hospital where there's a full complement of interdisciplinary team members 7 days a week. And, you know, but in other places, especially a lot of the more rural communities, that isn't necessarily always available. So having the standardized handout allows and empowers all different providers to have this conversation with their patients. So helps increase the confidence of the providers in having this conversation. It's also nice to have like an external tool uh, to kind of keep the focus of the patients and their families on the tool as opposed to the providers. That can really help maintain the rapport. And they don't remember like it's quote unquote you who's taking my license. So in terms of the resource development timeline, um, before 2018, there was pretty limited widely available resources. We'd see some hospital-specific information. When I was a student working in Toronto, uh, Toronto General had their own handout, or we would come across a really great piece of information that was out of the UK or was out of the United States, and it would have great information on like the deficits post-stroke and how it impacted driving. But the information regarding the rules or the Ministry of Transportation requirements or the licensure, um, that wouldn't be relevant. So um, in 2018, SWASN, the OT group, came up with a subcommittee to create some sort of standardized handout that we could use in our region to help address this topic. And I think this was really spurred on from the ministry, the new discretionary reporting for occupational therapists. And what they did was they came out with two booklets. I don't know if you can see it here. This is the first version. Large print. It was written in first person. Every booklet at the back had different appendices with aphasia-friendly versions over here. Um, but what we found, and it's of course with every new resource, as we use it in practice, we realize, there are some things that I would change from this. There were some limitations, of course, lots of text. There wasn't any pictures. It wasn't super eco-friendly as everybody got every single page. Even the people who didn't need the aphasia-friendly resources were getting the aphasia-friendly resources. So there was a couple of things that just through using it, we decided that, we could update this in the future. Between 2018 and 2024, other stroke networks across Ontario created their own version of this handout, really using it as that foundation, keeping the content the same, not needing to recreate the wheel. And then we have in 2024, again, the OT group in the SWASN came up with a subcommittee to update the version 1 of the document. How are we using this in our practice? What could be made better? So we came up with an updated layout. We added pictures. The focus really was on grouping information together. We added new content in alignment with the Canadian stroke best practices. And we also had these documents vetted through stakeholders. So we were in contact with emergency physicians, with neurologists, with patients, both in urban and rural areas. And I'll talk a little bit about this later, but these resources were meant to be used throughout the patient stroke journey in different ways. So the vision was we would be able to give this either as a full booklet or kind of piecemeal, one page at a time, depending on the patient needs. So let's take a quick look at the 2024 SWASN resources. And so these are all available in the handouts. So if you're on your web browser and you type in the Southwestern Ontario Stroke Network or even just SWASN, and you go to their website, there's two ways you can get to this. If you go to healthcare providers, you go down here to stroke resources. There's a whole section on return to driving. And so actually right up here is the return to work resources that was presented on earlier. But if you click on return to driving, so we came up with 4 different handouts. The one that we'll go into the most detail on is the return to driving after stroke booklet. We'll quickly look at the TIA one as well as the aphasia-friendly communication aids. So page 1 of the stroke, returning to driving after stroke booklet is really like a general information one pager. If you only have one page to get all of the information, this is what you need to know. It talks about driving after stroke and how a stroke might impact somebody's ability to drive. It discusses why someone can't return to driving right away, and it talks about license reporting. It also has some good information about, you know, what a patient needs to do in order to return to driving in a checklist form that's highlighted in red. Page 2 talks about different stroke effects and how they can impact driving. So common symptoms post-stroke and how they relate to driving. I really like this as a visual learner myself, and I use this a lot with my patients. And I highlight things, I star different sections, and it really helps connect the therapy activities that we're doing to how does this help them return to driving. If we're working on processing speed and reaction time, sustained attention, divided attention, they can see these are the things that you need to improve on in terms of returning to driving. And also be used to highlight progress over time. Page 3 is a flow chart to help the patient with decision making and visualizing those next steps, and kind of guides them through, what's the process of returning to driving. Page 4 is all about on-road assessments at a functional driving center. Now, this is something that can be quite nebulous. People who have had a stroke or people who haven't gone through some sort of medical event, this isn't something that they would have experience with from, their day-to-day life. Often patients are surprised that, hey, I have to do an on-road assessment, and that's somehow different than the drive test that they did when they were 16. So this page really talks about what to expect, what the referral process is, what the cost is, where to find functional assessments, and what to expect. Page 5 talks about retiring from driving. Some people choose to retire from driving after a significant medical event, and then some people, unfortunately, aren't able to return to driving safely. And so this talks about the importance of connecting with counseling, mental health resources, and kind of validates the feelings of like anger and frustration, loneliness, isolation that somebody might experience after being told that they can't return to driving. It also helps patients and their families create a transportation plan so that they're not feeling that they're, burdening one person or 2 people for all their transportation needs. And it also highlights Healthline, which is, we talked about it before in the leisure part, so I'm not going to talk too much about it, but it is an Ontario-wide online resource that connects people with programs in their community. And finally, page 6 just talks about roles and responsibilities. What is everybody's job as it relates to return to driving? We also have a driving after TIA handout. And again, this is something that is a little bit more nebulous. We don't have some strict guidelines for what to do for returning to driving after a TIA. So it talks about the rules in Ontario, and it talks about the process for return to driving. And this is just 2 pages. Now, we know that a lot of patients, I think the stat is approximately 30%, after stroke have difficulties with communication. And it's our job as healthcare providers to meet the patients where they are and still have this driving conversation with our patients that have aphasia in a way that they can understand and appreciate the information. And again, I know somebody's talking from the Aphasia Institute a little bit later, so I'm not going to go too much in depth with this. But we think about, oh, that on my screen, this was all nicely formatted, so the words didn't um, cross lines, but that's okay. So we think about three main areas of how can we support our patients in their understanding if they are experiencing aphasia. And so we talk about using communication tools, adapting our provider communication style, and really optimizing the environment. So a communication tool that is aphasia friendly will use a lot of keywords. It will use bolded print as well as have pictures to support what you're trying to discuss. But just using a communication tool alone is not enough in order for something to be aphasia friendly. So we need to, keep our volume at the same level, but really slowing our pace, allowing for frequent pauses, using gestures, maybe a communication board, and taking time to validate the patient and the family's understanding at various points throughout the conversation. We also talk about optimizing the environment. So reducing visual and audio distractions, having family members be present. So keeping these um, guidelines in mind, we did create two aphasia-friendly toolkits that can help have this conversations with our patients that have aphasia. And again, liaising with our speech colleagues is helpful in this aspect as well. So we have one for when their license was suspended, and we have one for the license not being suspended. So I'm not going to go over this in detail. Please feel free to peruse these at your leisure. In terms of using these resources, the Driving After TIA was really designed to be used in primary care offices, ER departments, secondary stroke prevention clinics. We often don't see people who have had a TIA be admitted to the hospital because by nature of the diagnosis, their symptoms should be transient. The Driving After Stroke, I kind of alluded to this before. You can give it as a full booklet, or you can use individual pages. So maybe on an acute inpatient, maybe the patient and their family can only take in the first page because there's so much else going on. And then maybe once they're on rehab, then they're given a little bit more information, pages 1 to 3. And then in the community, when they're referred to an on-road assessment or they want to talk about retirement from driving, that's when they get those pages. So, using your clinical judgment is important here. Some people want all of the information right at once. Then others, it might be better to just kind of give them a little piece at a time. And then, of course, the aphasia-friendly resources. Often they're used a little bit more in the inpatient setting, but they can also be used in the community as well. They're pretty self-explanatory. So in our last couple minutes, I'll take you through a quick case study, seeing how we would use these materials in a real world setting. So this is Mr. Barnes. He's a 72-year-old male, and he experienced a left CVA resulting in aphasia and some right-sided impairments. Previously very active in the community, retired millwright. He volunteered as a community driver, choice fishing, spending time with his grandchildren. So Mr. Barnes received TNK and was admitted to the ICU, followed by transfer to the stroke unit, where he started his engagement with therapies. So from a speech perspective, he was having difficulty with speech production, comprehension, reading, writing. Communication with the medical team was quite challenging. I'm going to leave the OT and the PT information up there. I'm just for sake of time, I'm not going to go through it all right now. But in Mr. Barnes's stroke journey, it was determined that his license was reported. And so using the aphasia-friendly tool, the license suspension, is helpful to communicate that license suspension to Mr. Barnes and his family. So having that conversation with family members present is helpful. And again, using those provider communication styles in order to best support him and his family. Also important, consider following up with social work if that is available to you in your center to address that emotional response to the license suspension. Sometimes family wants a little bit more information. So of course, you know, using your clinical judgment, do they want the whole handout? Maybe they just need the first page to just kind of wrap their mind around the implications. So Mr. Barnes then moves to the rehab unit where he spends 6 weeks, makes lots of progress in his therapies, improved reading comprehension, but does still have ongoing difficulty with speech production, processing speed of written and spoken language. The aphasia really impacted the ability to administer formal cognitive and perceptual assessments. And so really on the rehab stay, your clinical consideration is liaising with speech to optimize communication, identify appropriate formal assessments, as well as, you know, maybe this is a really great spot. Mr. Barnes has progressed. This is where you can use pages like 1 and 2. Using blocking strategies. Okay, we're going to talk about the speech and language deficits. Let's block everything else. We'll highlight, and we'll leave that information with Mr. Barnes and his family. Before discharge, you can review that flow chart with him and kind of talk about what the next steps are. And this is also where that possibility of an on-road assessment can first be broached. In the community, Mr. Barnes attended 6 months of outpatient therapy, where he continued to make gains. His speech fluency was improved, but was impacted by high stress scenarios. Cognitive and perceptual screens were pretty borderline. So at his initial outpatient goal setting session, you know, reviewing the process of return to driving. So many times I have patients come in that are like, oh, I never got that handout, where maybe I was the person that gave it to them. So like, I know you got it. But of course, in the chaos of being in hospital, they're getting so much information, they're going home, you know, things go missing. Absolutely. Here's the opportunity to review the process, give the handout again. You can use that page 2 as that reassessment, and say, hey, you know, you've made so many gains in these areas. Here's where you're still kind of having some difficulty. In this case, an on-road assessment is necessary. So reviewing what to expect using page 4 with Mr. Barnes to prepare him for that on-road assessment. If he is cleared to return to driving, creation of a communication card for use in emergency situations can be really, really important. As in this case, Mr. Barnes, his speech fluency was impacted by high stress scenarios. So that can really lead to some miscommunications and assumptions if he gets in an accident or something happens, right? So having a card that says, I have aphasia, you know, I can understand, but sometimes speech production is challenging, can help. Now, of course, in a ideal scenario, as an OT, I want everybody to get back to everything that they want to do. So in an ideal scenario, he'd do the on-road assessment, he'd be cleared to return to driving, and all would be well. Sometimes, though, that isn't the case. Or sometimes we see patients who decide, you know, I feel too nervous. I don't think I'm safe to return to driving. I don't really want to return to driving. So if somebody's contemplating retiring from driving, using that last page on retiring from driving is a really nice, again, one-pager handout you can give to Mr. Barnes and his family. It helps you as the provider come through with that alternate transportation plan. You can help investigate the appropriateness of accessible transit or see if there's any community programs that offer transportation. Working with the SLP, another communication card, using a taxi service, and of course, referring for counseling as needed. Just really briefly in our last couple of minutes, I do want to highlight some of these other resources. I won't take you through it all. The CMA Driver's Guide is available. I actually found it online. If you just type in CMA Driver's Guide, it's like a 155-page document, but it talks about different medical conditions, what the guidelines are for returning to driving. Lots of really great information. It is based on the next bullet point there, the CCMTA. And that's an even longer document. The SWASM website that I showed you is really wonderful as well. Healthline, the Canadian Stroke Best Practices website. Actually, the College of Occupational Therapists of Ontario has a really wonderful guide to discretionary reporting if people aren't feeling super comfortable with having that talking. And of course, there's other handouts, the Aphasia Institute. I'll briefly share my references. You can look at that in your slides. Sorry, I'm chatty, so I ran a little bit late, but I'll stop sharing my screen and I'll open it up to some questions.
Thanks, Jeanette. Very, very interesting. Lots of questions coming to the chat. Some of them I think will be answered in our next talk, which is on determining medical fitness to drive. And I know Wendy is online answering a few of the questions as she can. But I'll start with the first question that came about partway through your talk. Do you think there is an issue with some medical professionals not understanding that the inability to verbally express what a sign says is not the same as not understanding what the sign says?
Yes, absolutely. It's return to driving is such a nuanced and complicated task that in order to really get a sense of what is involved, it can be really challenging for somebody who doesn't have a formal education in it. And that is absolutely something that we look into, and aphasia in particular is quite challenging to assess. Not a lot of our assessments that are validated for driving are, for use for people who have aphasia. So, especially something like street signs, like I have come up with my own way of informally assessing what street signs in my own personal practice. But I think that's something that is really missed a lot in the day-to-day for people who don't deal with return to driving every day.
Right. Kind of leads to the next question was people are asking if you could elaborate on the in-depth assessment and treatment that OTs in rehab and community who are not certified in driving assessments, as OTs and functional assessment centers are, what they should do or what assessments they should use.
Yeah, so actually the Canadian Stroke Best Practices website has a really wonderful list of assessments and their recommendations for kind of return to driving. I've kind of created my own battery of assessments that I like to do. But really, when we talk about occupational therapists in the community, the gold standard is an on-road assessment. So what we can do is we can screen for deficits from the stroke that may impact driving. We are not assessing capacity to drive because we don't have them in the car, right? And so we can say, hey, we're assessing the components of driving, whether it's physical, cognitive, perceptual, like a neurovisual and vestibular, language and comprehension, that sort of thing. I also like to flag any like medical issues, and then I'll send a report like that to the doctor. So we can screen for components related to driving that may have been affected from the stroke, but you're not assessing driving ability. And I think that will be talked more about after this.
Thank you. Okay. Just a quick question about your team. In your team, who reports to MTO? Do you send a discretionary report or make a recommendation to the physician for a mandatory report to be sent?
So often this happens on the inpatient unit. Our OTs are quite comfortable with completing discretionary reports. Sometimes it is a conversation with a doctor, but we don't necessarily need to have them on board in order to submit that discretionary report. It is a little bit more challenging for somebody who doesn't have a family doctor. Who has more barriers to returning to driving. But there are, of course, there's no one right answer, and it can be really, really challenging.
Yeah, for sure. There's a couple of questions about financial assistance and modifications, and I know Wendy was able to go in and provide some answers. So as it's 1:15, I'll maybe give you, Jeanette, the opportunity to go into the chat after and also reply to those last couple of questions if you have a
Yeah,
few minutes.
absolutely.
And we'll wrap up our talk. Thank you so much. It was really helpful. I'm really glad to have the resources and to be able to share those with everybody across the Northeast. I think we'll find them quite useful in moving forward with our work. So we appreciate that you took the time to come today. Thank you very much.
Thank you.